Welcome back to Sports Medicine on Tap. My name is Brandon Elia, live from the NATA Expo floor in Philadelphia with our good friends Dr. Frey and Dr. Bertha and our special guest, Dr. Rutger Adkins from Thomas Jefferson University. Rutger, what's up, man?
Thanks for having me, guys.
Yeah, thank you. Thanks for coming on.
Yeah. So Rutger and I go back a little bit. We went to Temple together and got our DATs back in 2018 now. We're almost a decade out, which is kind of crazy.
Dinosaurs.
So thanks for coming on, Rutger. I'm glad that we've kept in touch in this time. And I've been trying to get you on since I think we talked about it last NATA when we were down in Orlando or whatever the case is. But now we made it work. So thank you. Welcome.
Yeah, I'm really excited. Long time listener, first time caller. So yeah, I'm really happy to be here. But it's a podcast and really not online. I know we got a little bit of video, but I've been told I have a face for the radio. So
there you go. Well done.
Appreciate it.
Unfortunately, we don't have any brew dogs with us too.
Yeah.
That's the downside.
Next time
of the
around of being here.
Yeah.
That's what I said to Brandon. I said, next time if I pass the initial screening here, we can do one with the little more liquid courage.
There you go. Open up the conversation.
Yeah.
Some very interesting sort of philosophy or a different approach to some concussion management that you were working on, you had come up with in terms of some AI and some concussion type management philosophies.
Yeah, so a couple years ago, Zach White, DAT, with Brandon and I graduated with Temple, asked me to come and help them out from a medical observer perspective for the American Conference. And in doing so, I brought my philosophy with me, and he and I obviously been working on this from a policy and procedure standpoint to really identify how this cumulative load during the course of a Division I football game can really impact athletes from a physiological perspective. A lot of things that we just can't assess yet well from a medical perspective.
Right.
So when we consider what we're doing from a video observation with the replay and all the different angles, how can we identify those folks and put them into different risk categories? So if we see that, let's say a middle linebacker goes through several tackles, of which, they have a, side of the head impact. There's also like an emotional category that I added into it as well.
Right.
So, football's a really exciting game to watch, but if a player gets up and, they're really shaken and really fired up after a play, but it wasn't really game changing, that's a part of what I'm looking for as an assessment.
Right.
So, as I put a couple pins as I go through one particular athlete, I start to, take notes for each individual play, what that looked like. And then from there, Zach and the team and I obviously are looking at how they progress throughout the game. And what will determine at any given point in time, even if there's a larger kinetic moment, we are looking at, hey, this is an immediate evaluation that's getting them in the 10 on the sideline, or this could be a delayed evaluation where we can look more at them, at the next stoppage of play, or if we have to pull them. So it really was helpful for the last, I'd say, season. We really hit our stride, and he asked me to come in for the Alliance in Intercollegiate Sports Medicine. So it's with the Big East and the American Conference get together, and I presented this, and it was really well received.
So is it the system? Is it dynamically changed then? Like, if you have these players that you watch on a week-to-week basis, do you learn their prior behaviors on prior games and then see those change in subsequent games, or is it on a game-by-game basis?
Well, you look at it like it's healthcare on a continuum, right? So these individuals come in with the history from the previous game.
So it keeps all that.
It keeps all that. And then so from there, all right, how are we managing this player's time throughout Zach, Bailey, and the team at Temple now look at this from like, all right, how are we looking at this individual just from a cumulative load during the week? Yeah. So that carries over every single time. And what we were able to do, I think, from a performance perspective, which is more of a performance model truly, is say, hey, what are we doing and how are we using best practices? So, even and it's not just me, I'm not the only set of eyes out there. So everybody's watching the play, and whoever is, really, keeping their eyes on the field because it's their given part of the team. Hey, started that for the QB, I saw this, Rutger, can you go back and watch this? So it's also retrospective. So it's kind of nice to be able to sit and go back and say, hey, we can look at these symptoms that this athlete's having, and this was a substantial load. This was a substantial impact. This puts them in this category. What's our treatment after the game? So it's not even just determining participation level, but what are we doing to actively treat them following that, game?
So it's as opposed to like one specific hit or one specific injury, you're kind of monitoring, and I'm just going right up the
Base level.
Yeah.
How things kind of change of each.
Like, all right, he's had multiple hits in this game that were a little bit higher, or his reaction wasn't what I would have anticipated. Right. Is that an indicator that he's heading down a pathway and a little more susceptible, or we have to keep?
Yeah, so when we start to really look at how the white matter and the fluid within the brain starts to flow following just small subconcussive impacts, right, we start to see that we're not just observing one kinetic thing that causes this mild traumatic brain injury.
Right.
This is stuff that's happening on an ongoing basis, no matter what. Right. So, sure. All right, we look at this as not just the brain, but how's the cervical spine, upper airway responding to this chronic load and inflammation processes that infect us from a even pathophysiological perspective, depending on the patient's medical history as well. How does this ultimately cascade for us in knowing that the athlete's safe to return back to activity following? So, hey, this individual, let's say it's a defensive end, really slowing down, really, not getting to the ball, not making effective decisions. Like, you really start to even get a better idea of like just how that performance is affecting them on the field. Mm-hmm. And then it's like, hey, let's go evaluate them. And it's odd to say, like, I'm getting better at it because I'm looking at things not just where the ball is, but let's look at 3 yards out. If the play happens on either sideline, all of these things are higher risk factor that the athlete sustained a much larger load from that given play. Mm-hmm. They had to run further. It was a higher impact. That athlete got to run faster to get to that point. And so in those different categories, we did a really good job this past year of mitigating higher level injuries, and the outcome of the season was a positive one. So we're looking forward to seeing how we can potentially identify a way to build this out from a research perspective, so we can really look at how those patient outcomes can be viable for us moving forward and really developing this out. So I think the grand scheme of this is there's not a lot of training out there from concussion observation. There's not a lot of gold standards,
right?
From a standpoint of how are we doing this? So I think more so where I take away from this is looking at this from a different philosophical approach for those that are doing it. Hey, let's look at this from a grand scheme of things, really look at it from a continuum. And if we do that and you have some consistency in who that medical observer is, you can really change the outcome of the season based off of how you're approaching that.
So does it change also the management or how you evaluate the patients on the sideline after you've identified that there's these risk factors that you're seeing via video?
So, we try not to bias the examiner too much, right? Hey,
right, sure.
We identified that this person needs the evaluation. We give them a region. The clinician then goes through their evaluation, and then following from there, if they have a follow-up question, that's when I come to play. Hey, what was the extent of that? They need more information from me from what was the external stuff, because maybe it's not a clear view. Maybe we're thinking that this is more of a slower development in the patient's etiology and how they're presenting. Yeah. So if that's something that we can be a little bit more predictive about because we have that information and we have that lens, then we can make a clearer determination on return to play or how we're treating them.
Gotcha. So how about with like, I'm just thinking like a specific scenario, like an athlete, you're identifying these factors on the field, their change, maybe personality, mood swing, whatever have you, that they're doing out on the field, but you get to the sideline, you do their evaluation, everything from a testing standpoint is okay and normal.
Checks out.
Yeah. So what do you do, or what's the next steps for those kind of athletes?
That's our timeline, right? So now we have a baseline following that information that we have. So that's, again, somebody that gets a reevaluation as a delayed eval. So if we determine that, hey, this isn't a delayed eval, we want to get an evaluation on the sideline, there's somebody, hey, we're going to check in back with you halftime in the game or whatever that next break is, and then we get another idea on where we're at.
Gotcha.
So, okay, we may not see the onset of anything right now. That's what we have. That's best practice. All right, yeah, sure, you're clear to return, but we still have you as an at-risk.
Right.
So, all right, maybe it's not something that shows up in the next 24, 48 hours, but that 72-hour mark, wow, this athlete needs to see, some other type of workup or evaluation, and then we kind of go from there for looking at the longevity of their load throughout that week.
What was the measuring stick that you used at the end of the season to gauge that you did better than if you had not been putting this into practice?
So, arbitrarily, we really weren't able to go back and look at that information objectively because can't really truly do anything because we don't have IRB approval to really do human subject stuff. But from an anecdotal related perspective as clinicians, we were, really comfortable in how we went about the triage and care of the patients on a regular basis. Sure. And that evolved just the policy and how we're approaching everything.
Yeah.
So now it's not necessarily a set category of 5 things that we go then to the coaching staff and say, this person's limited by this or participates at this. It's now a list of 10 to a growing list, 12 categories, where now the coaching staff is much more intuitive into, I understand why this is taking place and what that plan of care looks like, and now the athletes, I think, are more receptive to it as well.
That was my next question. How is this received by athletes, right? Like, we've all had that scenario where you have someone who doesn't, refuses to come out of the game. You got to take his helmet. You got to protect the athlete from themselves. In general, across the board, is this received as these guys are really making it hard for me to continue to play and do my thing? Or is it more received as these guys are really taking care of me, keeping me healthy? Do you know what I mean? Because you're really, really
You're hitting the nail on the head, right? So I'm not a favorite, game day, right?
Yeah, no one wants to be anywhere near you.
But when you look at things retrospectively, they start to see, and when you're thinking about NIL, right? You're thinking about all the money that's going into collegiate sports. You're looking at us, hey, this is a comprehensive, ongoing evaluation that I receive as a part of my care, and that I don't have to, for myself, mitigate symptoms or not report anything. No, if I denote this sooner than later, and it's identified, even if I don't openly admit that I have some subset of symptoms, we're not relying on that subjective information. So it takes the athlete into more of a true autonomous position where they can just be an athlete, and honest and perform at their best level, and know that hey, looking at the concussion stuff, looking at everything that's come out, should we look at this as I wish I had this a couple years ago, right? So I think I'm a little bit of a thorn in people's side when the big lights are on, TV spotlights on you, and you're wanting to perform, families in the crowd, what have you. But at the end of the day, it's you're in the locker room at the end of the day, everything's kind of starting to calm down. It's a very, very warm environment, and I think the athletes really receive it well.
Yeah. So what's some of the things that AI has encountered that you feel like is hey, you and I on a typical basis wouldn't really have picked up on? What are some of the signs and symptoms that we're seeing?
So AI in general, I use this from educational perspective, policy management, and then ultimately we really are having to safeguard a lot of this information, because if you're not doing it behind particular firewalls, restraints, you can't put, protected information, private information in there. What's been beneficial is, okay, we are looking into doing this and identifying this. Can you help me to design what this looks like from, let's say, a rubric perspective? And this could be inside the classroom and outside the classroom, giving us different identifiers, having a much more objective view. And so with those larger language model AI platforms that can really help you to think a little bit more outside the box, even though you're creating everything in little boxes, we're missing a lot less that we probably weren't able to be quantifiable about as an individual. So I think it really does help from an efficiency standpoint, no matter what side of the fence you're sitting on.
Go ahead. I'm sorry.
No, I think I was gonna kind of just say in that aspect of efficiency when it comes to AI in the world of AI and athletic training, sports medicine. It's not going to replace the actual clinician and what they see, but efficiency, is going to give you a better flow to what you're doing, and it's going to, from an education standpoint, you'll have that out in front of a student or whatever the case is, so they can feel more comfortable flowing through that evaluation and know what they're looking for or whatever the case is. So I think that's one of the best pieces of AI is the efficiency piece.
We have over 150 episodes on this podcast, and we haven't done it. We've done multiple episodes on concussions. We haven't done an episode on CTE, on chronic traumatic encephalopathy, and part of it is we don't know a whole lot. We just don't, right? There's so many variables, and and I feel like this is starting us down that pathway. Actually, to think about it from this perspective, is this the beginnings and maybe some eventually some substantial information regarding CTE down the line. Like it's a really on the smallest version of it, like almost that.
Yeah, I think when we start to define things, we tend to get ourselves a little bit in trouble because we start to lose sight of the fundamental stuff as well as really best practices. And I think if we wanted to do well from concussion, mild traumatic brain injury, however we want to identify, that this load is happening for these individuals, what are we doing from an educational perspective to help folks to do the best for those in those, vulnerable positions? So younger athletes, folks that present with, they're not in the neurodiverse population, but when I look at athletes that have a different subset of subjective or objective information within their medical history, that doesn't really follow an algorithm that you would say is, more cookie cutter about how they should respond to chronic stress or neurological stress for that matter. We've just started to scratch the surface on how we need to take care of these folks and identify them.
Right.
So from even looking at genetics, genetic factors towards chronic inflammation, responses to chronic inflammation, and how it goes to just tissue adaptability. CTE, I think, is just us starting to bring attention to it through one definition.
Right.
But that's been my point about addressing the, observation and use of, my clinical philosophy is we're just trying to diagnose. And I think sometimes over-diagnosing based off of subjective patient, presentation, we tend to get in a little bit of trouble. Yeah.
Do you find, because that was kind of my take on this, is that I'm assuming you probably find more irregularities than what you normally would have just based on, the typical evaluation. So I'm guessing, there's probably more evaluation than what you normally would have. But do you ever find that the contrary end? Do you find that there's ones that the AI is missing that's not identifying, or is it pretty robust from identifying these?
Well, it can only go off the information we've provided it. Yeah. So I think in where we can really strive as a, healthcare, team is to look at this and say, well, where we made the mistakes in the past, we have a little bit more of a historical aspect to it and say, all right, well, let's not just necessarily say this person is weak. This person's not tough. This person is looking for excuses or even a troublemaker. I think what we need to look at this is not necessarily, again, like bringing it back to the, observation conversation. It's not one kinetic moment that is, creating these situations where athletes are vulnerable. It's everything before and after. So, even taking prevention, in its whole. So primary, secondary, tertiary prevention, right? AI is not even able to get us to that point from how we're looking at and evaluating these individuals. And it's not even just from a concussive perspective. We're looking at how it impacts the entire body and musculoskeletal as well. So I think, where AI can really help us in this category is, again, condense it, make it something measurable that we can utilize based off of where we are and where we can start to mitigate those errors or mistakes that we have in the past. So as we kind of use it in tandem, we can see that scope of our practice really expands and is going to be a little bit more well-defined because we're measuring things a lot better.
Sure. I think it's funny. There's so many things, I think, in the medical world where we find exactly that. It's only as good as the data we give it or the questions we ask it. And it's just doing what we want it to do, so to speak. But no, very interesting stuff. Really cool.
And now, Ricker, that's like something you're doing on the side. That's not even that's not their primary driver.
That's just a consulting bit, right?
Yeah.
So as a DAT, really working outside of the primary responsibilities that I have with Thomas Jefferson University.
Right. Who's the supporting body at this point that's on board with what you're doing? And because I have to imagine it's probably going to grow, right? Like it's probably going to get bigger with time. Who at this point, who do you have? Is it Thomas Jefferson that's been institutional support, or is there a larger body here that you have on board?
So right now it's Temple University and my affiliations with colleagues at that institution. That really this is where the care is taking place.
Yeah.
Right.
So it's third party. Where Jefferson supports me is obviously from a service perspective, where I go out and do these things.
Yeah.
To show that clinical prowess or expertise.
Yeah.
That's where that necessarily comes in from, like a shared, expenditure. But it's really more on my time as opposed to,
Right.
really, taking bought time.
Yeah.
I think the bigger step next is the conversations that come after that presentation, that come after that year. So really having some high level conversations with some interested associations, other researchers, other collaborative clinicians that, like I said before, we would love to take a training. Could you maybe design one based off the information you've gathered? What does that research necessarily look like? And we're, approaching the literature from a different lens now to eventually create an IRB where we may be able to collect a little bit more objective data to support the decisions that we're making and maybe drive some of that force. And then from there, I welcome anybody and everybody to hop on board. Obviously a lot of the conversations I've had with organizations, like I mentioned, are very preliminary at this point.
Okay.
But a lot of people are, kind of leaving a bread trail crumbs for me right now. So I'm piecing the pieces together right now and seeing where that conversation takes me.
Yeah, it's certainly hard kind of piecing together that research aspect into kind of translational things and getting it out in the community. It's a hard process. Very time intensive and labor intensive.
It's a bear.
Yeah. But it's a worthwhile endeavor. Like, I think that, like, it's really, like, interesting and different point of view and a different approach. And I have a feeling it will get adopted over time. And interesting. Very interesting.
You were saying something earlier too, that there's some changes on kind of the educational front too for all this that you're trying to make.
Yeah. So I currently sit on the educational committee for the Eastern Athletic Trainers Association. And with that, we took a step back in what we looked at, like from a general charge. And originally it was a seminar before EATA even started. And it kind of stalled, I think, at some points. And as much as we like to think that this is, educational endeavor, all of this costs money. So if it's not, meeting, the bottom line, we're really not doing our, constituents a service, and we're certainly not doing our patients any benefit as well. So what we did was reevaluated our charge as a professional committee for the organization and said, where can we do a little bit better on a continuum? So giving programming throughout the year as opposed to just one point in time. And then what does that programming look like as we go through the year? And I think for that, my passion and reason in doing so, I think, we've heard the whispers, I've seen a couple Facebook comments, on social media, I've overheard, some whispers that athletic training is a dying profession. And I think that's, in a sense, a hard thing to hear, especially if you're a young entry-level clinician or you're considering it, for school. And my point that I always bring up to folks when they say that is, a tree has to lose some branches as it gets taller. So I think as athletic training matures as a profession, there are certain branches that used to be our, quote, bread and butter that are falling off a little bit because now we're starting to promote ourselves as a allied health professional or advanced practice practitioners as defined by the CATIE. And I think, what do we need to do to really bring back that spark for these entry-level clinicians as well as our seasoned folks to really say, all right, what are you doing that you could do better, right? Where can we really show folks that, all right, a certain pathology presents to you, musculoskeletal or other, and you're taking your best, known skill set, your professional network, and you are able to streamline that process and take care of people at the best, at literally the gold standard. And I think that is something that I've seen not necessarily fall off, but it's a little rarer than what we used to. I think there's a lot of folks that aren't problem solvers right now. It's more about like, what can, the supporting body do for me? And I think that is a little bit troublesome for me because folks look at the traditional athletic training body and setup as a profession as a handcuff. We can't go outside of this. We have to stay within these confines. We can't do things individually. And I think with that, we could do a little bit better if we support that from an educational perspective, even from an accredited or other programming. So in that, my hope and plan as we grow this a little bit more, let's add some awarding. Let's, from an educational perspective that isn't really captured from, the larger professional bodies. Let's do a little bit more for those within any role, whether it's an educator, a student, a preceptor, or other, shareholder, physicians, where we can start to show athletic training has this clinical prowess. We fit particular niches or gaps within the current medical model.
Right.
And, you could refer somebody to me and I could take really good care of them.
Right.
And in that, I really try to inspire my students as well as, those that I, see from a consulting perspective to say, you're in good hands. And this is how, students always come. They're like, well, how did you get from here to there? Well, I don't think students are the only ones that have the question. I think everybody has that question.
Yeah.
So if we can do that a little bit better from programming and my role from a service perspective, I'm doing what I do best, which is bring people together, motivate them, give them that spark, that passion to really, do their best. And I think in that, will all benefit as a whole.
Yeah, no, absolutely. I think it sounds like very much one of these things. If you're not at the table, you don't have a seat at the table, you're on the table.
Right.
Kind of thing. So you definitely have to be supporting yourself and be able to push those things forward. So it sounds like you're doing a great job for the next generation of getting people interested and continuing to grow the field and make sure it continues on in the way that it needs to.
Yeah, no, I think there's a lot of great athletic trainers out there doing really amazing things, and it's just a matter of giving them the opportunity to be in that spot, much like what you all are doing for me today. How do we afford that opportunity for other folks to really demonstrate that there are really passionate people that are out there really, pushing the line. Yeah. And how do we show that to other folks that really need to see that and benefit from that? Because we all have great ideas. We all have these inspiring concepts, and we all look at things through our given lenses. So just giving somebody, a cookie, they're going to want a glass of milk. Right. So in that, how are we doing that on an ongoing basis, making it consumable, helping people from an efficiency standpoint, and really bringing that, professional prowess and passion back to the profession.
I love it. That's awesome.
Yeah. Well, anything else before we go ahead and close out here? Ricker, thanks for your time. It's been great catching up, and I feel like we could do for another 2 hours of all the things that you're going on. Which we'll have to set up across the bridge when we go back to Jersey, and you're local, so we can set that up pretty easily.
Yeah, if you guys are going to make me talk more than a half hour, I'm going to get pretty thirsty.
All right, we got you covered.
Yeah, I appreciate it.
All right, well, Ricker, we appreciate your time. Good talking to you, good catching up, and we'll see you next time, folks.
Good stuff, man.
I appreciate it. Thank you very much.
We want to thank our sponsors who make this show possible. First, a quick word from Virtual Health. Runner's knee and dog walker's hip, they have a doc for that. Yard work back and laptop wrist, they have a doc for that too. Virtual Orthopedics and Spine has over 120 providers, over 20 PT and rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtual.org/ortho. Next up are a shout out to our friends over at Protected. If you've been listening for a while, you know we love Protected for getting elite athletes back in the game safely. For athletic trainers, this is an ultimate tool belt upgrade, a full suite of customized bracing products ordered via a quick 30-second 3D scan on an iPhone app. They are the go-to solution for custom face masks used across the NBA, WNBA, and Elite Soccer, AC joint pads that don't restrict range of motions, and hand and wrist splints that keep players totally functional. So go check out their 3D printed products in person and visit www.protect3d.io to learn more. We also want to give a massive thank you to our official NATA Row sponsor. NATA Radio Row is officially sponsored by Pivot Performance Turf. If you stop by our mobile studio layout on the expo floor, that incredible turf setup we were broadcasting on was all thanks to them. They kept our studio setup looking clean and professional all week long. And finally, today's episode is brought to you by Timbero Productions and our good friend Kyle, getting all this media out to all of our listeners. So thank you and enjoy the show.